So I've got a challenge of trying to explain modelling in, I was going to say 20 minutes, in 17 minutes. And I guess all of you here are interested in vaccines, but I'm guessing a good proportion of you might have been pleased to leave your maths behind. So I'll try not to do too much on the maths side. But what is a model? What am I talking about when I talk about modelling? Well, a model is a representation of the essential structure of some objective event in the real world. And a mathematical model, which is what we're dealing with here, is a description of that system using mathematical concepts and language. And these types of models are very widely used throughout the world, really. You could use it for population projections, weather forecasting, traffic flows, immunisation policy. And a model always just provides an approximation to the real world. But this approximation does allow you to sort of conduct experiments that you couldn't do otherwise. So you can run lots more experiments on your computer than you could by going out and doing a clinical trial. So it just allows you to a bit of flexibility like that. So I quite like this quote, all models are wrong, some models are useful, and hopefully some of the examples I can show you can convince you that the models can be useful. So why use models for vaccine decision making? There are several reasons. Firstly, by going through the modelling process, you need to have a good understanding of the epidemiology of infection, but it can highlight some areas where you can improve your understanding of the infection. And I'll give some examples of that. So you really better understand the dynamics of the disease that you're dealing with. An important reason for using modelling is that you can extrapolate beyond the results of a clinical trial. You might have an excellent clinical trial, performed by OVG maybe, that can give you all the answers you want in terms of making your decision for a vaccine policy, but that's highly unlikely. So you might need to extrapolate to different endpoints. Trials are usually reasonably small, so you could extrapolate the results of the trial on the number of immunogenicity to looking at the number of cases that vaccine might prevent, or the number of deaths that might prevent. You could extrapolate the results of a trial in one age group to a different age group. And I think importantly, you can extrapolate in your model the results of a trial to the whole population, which your trial is never going to, trials are small, they're never going to be able to do that. But if you're thinking about immunisation policy, it usually applies to a large subsection of the population or a particular age group, so you need to look at the population level effects. I mentioned that you can use models to simulate much wider range of options. You might have lots of ideas in mind of how you might schedule a vaccine, but conducting trials of every single possibility is very tricky, so you can use the models to do these simulations. And as Andy mentioned, there's a huge amount of information that committees like JCPI need to be able to look at. And modelling is one way of bringing together these different pieces of information and drawing them together in one framework. So it's a way of synthesising information as well. Another thing that modelling can do is tell you what you don't know. It's quite good at pointing out, we don't know what this piece of the puzzle is, as you're trying to fit the puzzle together. And that gives you an opportunity to perhaps go and design studies to address that issue. So here's quite an old example of the results from a mathematical model, and a classic example, really. I'd like to say that it's older than me, but that would be a terrible lie. So this early model looking at rubella just illustrates how the results that you can see from modelling might sometimes be a bit counterintuitive. You might think you have a new vaccine that can prevent an infection. Well, that can only be good news. But actually, if you looked at using this vaccine in a population, this figure shows the ratio of cases of rubella that occur in younger children compared to older adults. And if you introduce a poor immunisation programme with rubella, or with low coverage, you actually increase the ratio of cases that occur in women of childbearing age, which is bad news for rubella. So you have more cases of congenital rubella syndrome. And so this model is a classic example showing how you can use the information on the dynamics of the infection to see how a vaccination programme might work. And this is useful, and this was actually shown. This is a paper looking at rubella in Greece, and Greece did implement a relatively poor rubella immunisation policy, and they saw what the model had predicted many years before, that you shift the average age of infection, so you actually make your burden of disease worse in this example. So how is modelling used in the UK and in vaccine policy decisions? Well, actually, it's been used for quite a long time. It goes back to the days of the PHLS. It survived three different organisations. But PHE was the first national surveillance centre to incorporate modelling into its core activities. And the JCVI is really seen as having led the way in using models to inform vaccine policy, and has led the world in this respect. Some early examples of use of modelling include models that define the need for a 1994 measles rubella schools campaign, and in 1996 a second dose of MMR as a preschool booster, and modelling was used in these examples to inform the vaccine policy. So it's been around for quite a long time, and as Andy mentioned, it's now a routine part of the evaluation of the potential impact of a new vaccine programme, or indeed to look at changes to an existing programme. Economic analyses, so cost effectiveness studies, have become increasingly important over the years. So when I talk about modelling, there are really three different elements that go into modelling to inform vaccine policy decisions. The first one is a dynamic model. So the results from that rubella example I showed you is a result from a dynamic model, looking at what happens to the infection over time if you introduce a vaccine. And this is really where most of the maths comes in, and I'll explain a bit more about that shortly. The second element is using modelling to define the burden of disease. There are lots of different information sources on disease. For some infections it may be more straightforward than for others, but you may need to do some work to properly define the burden of disease when your information isn't perfect. And then the third element is to build in the economic analysis to these two components, the burden of disease and your dynamic model. So these are the three elements that go together. So what do I mean by a dynamic model? It's sometimes known as transmission models or transmission dynamic models, just infectious disease models, mathematical models. All these names mean the same thing, really. And the key concept behind this is that the risk of infection depends on the number of infectious people in the population. So if you introduce a vaccine, members of the population may benefit from the effects of the vaccine without directly receiving it. And these effects aren't linear. You can't say, well, a certain proportion, you immunise a certain proportion, so that will protect an additional proportion of people. It's dependent on the level of coverage, the infectiousness of the organism. So these effects are quite complex, which is why you need a mathematical model to underpin this. So for most infections or vaccines, a dynamic model should be used. There are exceptions to this, so if a vaccine doesn't influence transmission. I think you've heard a bit about shingles vaccine, so that's an infection that's already present in the individual, so you wouldn't need a transmission model to look at shingles. You wouldn't need a transmission model to look at tetanus, where it's acquired from external sources. But in many cases, a vaccine will affect ongoing transmission, so it's important to use this type of model. So here, just to show you, just to illustrate this, you have this disease that can be transmitted through the population, and each case leads to 3 more cases, and so the disease can spread exponentially through the population. If you introduce a vaccine, you can prevent 2/3 of infections, and that's the direct protection. So these people in the yellow circles are directly protected from their vaccine. But you're also preventing these onward chains of transmission. So all these additional people can be protected. And this is where these effects are non-linear. This is why you need your mathematical model to understand these sort of indirect effects of immunisation. What underpins these models? Well, you need to have a good understanding of the biology. It's always going to be simplification, but you need to understand the biological processes, and this is just a schematic of some of the things you might want to know. might want to know the force of infection, so the rate at which people become infected. Once they're infected, are they infectious straight away? Can they pass on the infection straight away? Is there a latent period where they're not infectious? And then what happens during the course of clinical disease, and then the outcomes probably become more important for the economic models than for the dynamic models. But you do need to have an understanding of the biology. And I think that's one of the reasons why the earliest examples were of these fairly well-characterised viral infections like measles and rubella, because they were very well understood. So your model could be characterised like this for the rubella example, for example. So you have those people who are susceptible. In this box, you can just classify people into compartments. You can say you're susceptible, you're infected, or you're immune, is R. And this is a typical model. People are born into the susceptible class and can die out of any of the classes. And if you, this lambda here, people become infected according to this force of infection and then recover according to another rate. So it's a fairly simple model, but can capture some of these important dynamics of infection. So if you just run this model without vaccination in your computer, into your computer program.
What do the individual symbols mean?
The individual symbols. So here in the boxes are just the so in the boxes, S represents a susceptible population. So everyone in your population is born into the susceptible class, so they're susceptible to infection. They then become infected according to this rate. This is the force of infection. And then once in here, they are infected and infectious. Okay? And then they move, this is the recovery rate, so they stay in this period, it might be a short amount of time, if it's something like measles or rubella, and then they can become immune. So this R means immune. So you've got these three categories of people in your population. This rate here is just death rates going out, people leaving the system. This rate here is people coming into the system. And this expression here is about vaccination. So if you introduce vaccine, what you do, instead of people being born into this category, you shove them straight over here. So this is a routine immunisation programme, for example, where we're immunising young children. And the people who don't get immunised still go in here and at risk of infection. So by adding this vaccination, you totally change the dynamics of the system. And something similar to this can reproduce the patterns I showed you for rubella. What about the burden of disease? So an important question for policymakers is, well, how many cases or deaths or quality adjusted life years might a vaccination programme save? And to be able to understand that, you need to know how many cases, deaths occur in the absence of vaccination. That's not always that straightforward. So if you look at this pyramid, deaths are probably well defined. You can use sources like death registrations. If the disease is severe, most cases will be hospitalised. Fairly good information, again, from hospital episode statistics. Medically attended infections, you could use information sources from GPs. And all of these, I guess, more severe infections will be captured through, or a proportion of will be captured through laboratory confirmation through existing surveillance systems. For some infections, it might be very important to know who are symptomatic, so they have the infection but are not ill enough to go to the doctor. And surveys can be used to try and capture that information, like flu survey. And then the number of people who are infected is actually very important to know in terms of modelling, but is often very difficult to define. You can use things like seroprevalence surveys to look at the proportion of people who are immune, so have been affected in the past. Or for something like meningococcal infection, you could do a carriage study to see how many people are asymptomatically colonised. So this is it can be a bit of a problem. If you think of an infection like pneumococcal infection, then this pyramid becomes pretty full. You have people who are carriers, so they're infected, but you can't observe those. You have to do special surveys. You might have children who have milder ear infections, but you don't observe them. You could look at the numbers of children attending a GP for otitis media, or for pneumonia, but you probably don't have much of a clue what proportion of those children actually have pneumococcal infection as opposed to another infection. So this is difficult. This is where more modelling might come in to estimate the burden of disease. And here is an example for pneumococcal pneumonia, where most pneumonia is just recorded as pneumonia or a lobar pneumonia, but you want to know what the causes might be. And here, Alessia Melagaro used the patterns of seasonality of the different infections to estimate what proportion of pneumonia was due to pneumococcus compared to other infections. So modelling can come in for estimating the burden of disease as well. So the JCVI are obliged to consider the cost effectiveness of a new vaccination programme, and this enables comparisons with other interventions, and has sort of grown in prominence, really, becoming more important as time has gone on. An example here for rotavirus vaccine, the initial JCVI statement on rotavirus vaccine in 2009 said that based on current prices, universal vaccination of children was highly unlikely to be cost effective. And so it wasn't recommended until several years later, presumably when someone did a good deal to get a cheaper vaccine. And I don't think there was a huge outcry when rotavirus wasn't introduced, unlike the situation for the new meningococcal vaccine, where the interim decision was not to recommend this, given that the vaccine was thought to be unlikely to be cost effective. So there was a sort of big outcry here, and I was involved in some of the modelling work around this. And in some ways, there was a bit of a backlash against the modelling process, and particularly the cost effectiveness analysis, and criticism of the reliance on modelling to guide decisions. And I think some of this criticism was fair, and the models were adapted to look at different parameters and different situations. And I think some of it perhaps was because the answer wasn't what was desired, rather than because they didn't like the rules. And this comes to another point. When you have these models, you can't just get one answer. Usually, there's a lot of uncertainty. So there's uncertainty about what type of model you should use, and you have to make a decision about that. Usually, they're quite complicated. It can be quite complicated to develop. So a choice of a particular type of model will be used. Other people might disagree with that choice. There's uncertainty about the structure of the model. So, does natural infection result in immunity? And that was a question that was raised particularly for HPV vaccines. And it affects the dynamics of the system, so it's quite important to consider. And one way around that is to run different assumptions. There's also uncertainty around the parameters you can put into your model. You can try and resolve that by doing systematic literature searches or meta-analyses, using clever statistical techniques, or by sort of using probabilistic sensitivity analysis, where you take a range of your parameter estimates and try to use all that information. But there really isn't one answer. This is a bit of an extreme example of how uncertainty was dealt with for HPV. So there were a huge number of different scenarios that were modelled, and a huge amount of work went into this. And luckily, the results were quite robust to this uncertainty. And they found that one of the key variables was the duration of vaccine protection, which I guess was not known at the time the decision was made to use the vaccines. So it had only been used for a limited time. So committees like the JCVI have to take a view on what they think the most suitable parameter is for that. So it's a bit of a whistle-stop tour, I'm afraid. I'll try and hang around a bit later if anyone wants to ask more detailed questions. So just to try and summarise what I've talked about very quickly, because I know I always talk too quickly if I've got a lot to cover. Models of vaccination programmes have been used to inform UK vaccine policy since the 1990s. And I think one of the reasons why they've been quite successful is because people are not sat in maths departments making up these models. Some people are sat in maths departments making up these models, but the people who are informing policy are actually embedded in the public health system. So if they come up with something daft, or something incomprehensible, someone will say, what are you on about? What are you talking about? And that, I think that's one of the reasons why it has been useful. I talked about some of the three main elements of modelling, so the burden of disease, the dynamic model and the economic model, which all come together to inform vaccine policy. The models can be complex. I showed you a fairly simple model there, but they can be much more complex and depends on the infection. I think one of the key points is that it should be as simple as possible. They shouldn't build in complexity for complexity's sake. And if you struggle to understand the model structures and the dynamics, the model dynamics, I think papers should always make the assumptions and parameters clear. So you should always be able to find the table in there which says what we assume a vaccine efficacy of 90%, or we assume the cost of illness is this much. So that should always be very clear, so that it should be comprehensible. And another point, the models don't come up with one answer. Certainly they never come up with a right answer, because there is no right answer of these models. And where there is uncertainty, this should be properly acknowledged and handled perhaps in this way of doing scenario analyses or sensitivity analysis. So I thank John Edmonds, who I've pitched a few slides from here.